retina. The first talk is by Dr. Jasmin. Madam is Associate Professor GMC Kollam. She will be talking on corneal lesions of herpes simplex. Over to you, ma'am.
Good morning, all. Let me first of all thank Dr. Papa and KSOS for giving me this opportunity. Topic given for me is corneal lesions in herpes simplex. We all know HSV is endemic throughout the world, and it is common cause for unilateral blindness in both developing and developed countries, and is a very common in causing recurrent corneal ulcers. About the virus, it is a double-stranded DNA virus, and humans are the only natural host. There are two types of herpes virus, type 1 and type 2. Type 1 is associated with ocular and facial lesions, and type 2 associated with genital lesions. Its clinical manifestations are congenital and neonatal ocular herpes, primary ocular herpes, and recurrent ocular herpes. Congenital and neonatal ocular herpes, it is acquired from genital herpes from mother and 80% by HSV2. Ocular manifestations are periocular skin lesions, conjunctivitis, epithelial and stromal keratitis, cataract, and necrotizing chorioretinitis. By the age of, about the primary ocular herpes, by the age of 5 years, nearly 60% of the population has been infected with HSV, and it causes acute follicular conjunctivitis, keratoconjunctivitis, preauricular adenopathy, and periocular and eyelid skin lesions. Infections are usually mild and they won't reach to the doctor. So, after the primary infection, HSV travels in a retrograde fashion to various ganglia, including trigeminal ganglia, where when the host immunity decreases, reactivation occurs and it causes recurrent infection. So, what we are seeing in our clinics are recurrent infection. Primary infections, usually they won't seek medical attention. And following some triggering factors, they usually cause recurrences like fever, following cataract surgery, some excimer laser, PRP lasers, etc. This is the classification of recurrent HSV keratitis: infectious epithelial keratitis, neurotropic keratopathy, stromal keratitis, and endothelitis. Infectious epithelial keratitis usually present with pain, photophobia, and watering. The earliest lesions present as multiple vesicles. Within 24 hours, the vesicles turn to typical dendritic or geographic ulcer. This is the typical dendritic ulcer. It is the most common presentation. It causes branching linear lesions with terminal bulbs which contain live virus, and it is a true ulcer. It extends through the basement membrane. It stains positively with fluorescent along the length and at the margin swollen epithelial cells with the rose bengal. And next, if suppose we are treating dendritic ulcer with steroids, it can progress to dendritic ulcer, progress to geographical ulcer. It is also a true ulcer with, it is no longer dendritic linear, it contains swollen epithelial borders with live virus, and it has geographic borders. Another condition is marginal ulcer. It is usually confused with staphylococcal marginal disease. It is more symptomatic and may need topical corticosteroid. Sickle, it can cause complete resolution, can cause dendritic epitheliopathy, and stromal scarring like ghost figures and footprints, and 25% can progress to stromal disease. About the neurotropic keratopathy, usually by topical antiviral drops, it will heal by 2 weeks. Suppose the epithelial ulcer is not healing by 2 weeks, you can suspect neurotropic keratopathy. It is neither immune nor infectious. It is due to corneal impaired corneal innervation and combination with decreased tear secretion. It is usually seen in the interpalpable region, round or oval shape ulcer. Next is the stromal keratitis, two types, necrotizing stromal keratitis and immune stromal keratitis. Necrotizing stromal keratitis, by the direct viral invasion, the clinical features are causing ulceration, necrosis and dense infiltration of the stroma with overlying epithelial defect. The severe inflammation can lead to thinning and perforation. It can mimic microbial keratitis. So you should suspect a microbial keratitis with, otherwise we will miss it. When will you suspect? That is due to chronic history, recurrent episode, granular whitish infiltration with epithelial defect, minimal discharge and slough, vascularization, corneal sensation is decreased, footprint scars, atrophic iris atrophy, no photophobia, not very symptomatic. If pain is present, it may be due to uveitis. So whenever the patient comes, patient will be asymptomatic due to the decreased corneal sensation. Immune stromal keratitis, it is the chronic recurrent manifestation due to the retained antigen. There will be, epithelium will be intact and the stromal infiltration may be focal, multifocal and diffuse. Usually we get neovascularization and ghost vessels. Next is the endotheliitis. The target of inflammation is the endothelium, which causes endothelial dysfunction. There won't be stromal infiltration. Other findings are keratic precipitates, overlying stromal and epithelial edema and iritis. 3 forms are there: disciform, diffuse and linear. Disciform is disc-shaped distribution in the central part with overlying keratic precipitates and overlying stromal edema. Another one is the diffuse. The keratic precipitates may be distributed throughout the endothelium. And next is the keratic precipitates. It's line of keratic precipitates from the limbus to the central area. Thank you.
Thank you, Madam.